Thyrotoxicosis. It's a condition that results from any increased TH levels and can result from dysfunction of, I don't know what that's supposed to say. It says the beauty. I'm sorry. All of my pauses are me trying to figure out what you were trying to say. I'm sorry. It's so funny. I love it. The thyroid gland, ectopic thyroid tissue, or the ingestion of excessive amounts of thyroid medication. Hyperthyroidism is a form of thyrotoxicosis in which excessive amounts of THC are secreted from the thyroid gland. Primary hyperthyroidism results from thyroid gland dysfunction and is mostly caused by Graves' disease, toxic multinodular goiter, and solitary toxic adenoma. Central or secondary hyperthyroidism is less common and is caused by TSH secreting pituitary adenomas. So clinical manifestations, they are attributed to the metabolic effects of increased circulating levels of thyroid hormone, an increase in metabolic rate with heat intolerance, and increased tissue sensitivity to stimulate sympathetic nervous system, thin hair, exophthalmos, that's the bulging eyeballs, enlarged thyroid with diffuse warm on palpitation, nodular, toxic nodule, heart failure, tachycardia, weight loss, diarrhea, warm skin, sweaty palms, hyperreflexia, and pretibial edema. Elevated serum thyroxine or T4 and T3 levels are suppressed. Serum TSH levels are diagnosed for primary hyperthyroidism. Treatment is directed at controlling excessive thyroid production. Secretion or action involves antithyroid drug therapy, radioactive iodine therapy, or surgical removal of nodules or part of the thyroid gland. Graves' disease, the underlying cause of 50 to 80% of cases of hyperthyroidism. Genetic factors interacting with environmental triggers play an important role in the pathogenesis. It's classified as an autoimmune disease that results from a form of type 2 hypersensitivity in which there is a stimulation of the thyroid by autoantibodies directed against the TSH receptors. Autoantibodies are called thyroid stimulating immunoglobulin or thyroid receptor antibodies, override the normal regulatory mechanisms. Stimulation of TSH receptors in the gland result in hyperplasia of the gland or goiter is increased synthesis of thyroid, especially of the T3 levels. Increased levels of TSH result in the classic signs and symptoms of hyperthyroidism. TSH production by the pituitary is prohibited through the usual negative feedback loop. Those who have Graves' disease and have high levels of TSH experience pretibial myxedema, characterized by subcutaneous swelling on the anterior portions of the legs, indurated and erythematous skin. This is associated with TSI simulation of fibroblasts and T lymphocytes, causing excessive amounts of hyaluronic acid production in the dermis and subcutaneous tissue. Hyperthyroidism resulting from nodule thyroid disease. The thyroid gland normally enlarges in response to the increased demand of TSH that occurs in puberty, pregnancy, and iron, as well as individuals with immunologic, viral, or genetic disorders. When the condition resulting is increased TSH resolves, TSH secretion normally subsides and the thyroid gland returns to its original, I'm thinking that's supposed to be size. Maybe reversible. Changes can occur in some follicular cells so that these cells form nodules that function autonomously and produce excessive amounts of TSH. Toxic multinodular goiter occurs when there are several hyperfunctioning nodules leading to hyperthyroidism. Unlike Graves' disease, there is an absence of autoimmune stimulus. If there is only one nodule that is hyperfunctioning, it is termed toxic adenoma, where manifestations develop slowly and exophthalmos and heritable myxedema do not occur. Nodules can be palpable on physical exam, and there is an increased uptake of radioactive iodine with an increased incidence of malignancy. In the toxic goiter, most individuals undergo a fine needle aspiration biopsy of suspicious nodules before treatment. Treatment consists of combination of radioactive iodine, surgery, and antithyroid medications. Radioactive iodine may increase risk of solid cancer-related death, including breast cancer death. Thyrotoxic crisis is a rare but dangerous worsening of the thyrotoxic state in which thyroid levels rise dramatically and death can occur within 48 hours without treatment. The condition may develop spontaneously, but still occurs in individuals who have undiagnosed or partially treated Graves' disease and who are subjected to physiological stress such as infection, pulmonary or cardiovascular disorders, trauma, seizure, surgery, obstetric complications, or dialysis. Clinical manifestations include hyperthermia, tachycardia, atrial tachydysrhythmias, heart failure, agitation or delirium, nausea, vomiting, and diarrhea, contributing to fluid volume depletion. Treatment includes drugs that block THC synthesis, propylethuracil or methimazole, beta blockers, glucocorticoid steroids, iodine, and supportive care. Hypothyroid results from a deficient production of thyroid hormone by the thyroid gland. This is the most common disorder of thyroid function and occurs most commonly in women. Primary hypothyroid accounts for majority of cases. Central or secondary hypothyroid is much less common as related to either pituitary or hypothalamic failure. Subclinical hypothyroidism is a mild thyroid failure defined as an elevation in TSH levels with normal levels of circulating thyroid hormone. Primary hypothyroidism is the loss of thyroid function that leads to decreased production of thyroid hormone and increased creation of thyroid stimulating hormone and TRH levels. The most common cause includes autoimmune thyroiditis or Hashimoto disease, iatrogenic loss of thyroid tissue after surgical or radioactive treatment for hyperthyroidism, or after head and neck radiation therapy, medications such as lithium and amiodarone, and endemic iodine deficiency. Children may present due to congenital defects. Central or secondary hypothyroidism is caused by the pituitary's failure to synthesize adequate amounts of TSH or a lack of TRH. Pituitary tumors compress surrounding pituitary cells, and the consequences of their treatment are the most common cause of central hypothyroidism. Other causes include TBI, subarachnoid hemorrhage, or pituitary infarct. Clinical manifestations generally affect all body systems and occurs insidiously over months or years. Symptoms include loss of hair, coarse or brittle hair, periorbital edema, puffy face, normal or small thyroid, heart failure and bradycardia, constipation, cold intolerance, muscle weakness, and edema of the extremities. The characteristic sign of severe longstanding hypothyroidism is myxedema, which results from the altered composition of the dermis and other tissue. The tongue and laryngeal and pharyngeal mucosa membranes thicken, producing thick, slurred speech and hoarseness. Myxedema coma is a medical emergency and is diminished level of consciousness associated with severe hypothyroidism. Narcotics and sedatives or after acute illness and hypothyroid individuals can also cause this. Evaluation and treatment. Diagnosis is made by clinical symptoms and measurement of increased levels of TSH and decreased levels of thyroid, which is a total of T3 and both free T4 for primary hypothyroidism. Central hypothyroidism is diagnosed by finding low TSH and low serum TSH levels. Hormone replacement therapy with hormone levothyroxine is treatment of choice for both primary and central thyroid disorders. Hashimoto's disease is the most common cause of primary hypothyroidism in the U.S. and is autoimmune thyroiditis. This results in gradual inflammatory destruction of thyroid tissue and is linked with several genetic risk factors and is often associated with other autoimmune conditions. T lymphocytes, anti-thyroid antibodies, and natural color cells induces inflammation, glandular apoptosis, and tissue destruction. Uncommon causes of hypothyroidism: subacute thyroiditis and postpartum thyroiditis. Subacute thyroiditis is a rare non-bacterial inflammation of the thyroid gland, often preceded by a viral infection, and is accompanied by fever, tenderness, and enlargement of the thyroid gland in transient hypothyroidism before the gland recovers normal activity. Symptoms may last 2 to 4 months. NSAIDs or steroids usually resolve the symptoms. Postpartum thyroiditis generally occurs up to 6 months after giving birth with a core similar subacute thyroiditis. Iatrogenic hypothyroidism results from the ablation of the thyroid gland during treatment of hyperthyroid conditions. Congenital hypothyroidism occurs in infants when thyroid tissue is absent or with hereditary defects in thyroid hormone synthesis. The affected fetus is dependent on maternal thyroxine for the first 20 weeks of gestation and then becomes deficient in thyroid hormone, which is essential for fetal growth and the development of brain tissue. So the infant will suffer developmental and cognitive disabilities if left untreated. Symptoms may include high birth rate, hypothermia, delay in passing meconium, and neonatal jaundice. I'm thinking that's high birth weight. Cord blood can be examined in the first few days of life for measurement of T4 and TSH levels. Normal growth and intellectual functioning is still achievable if the child receives treatment between 3 and 4 months of age. Without screening, hypothyroidism may not be evident until 4 months of age, with symptoms including difficulty eating, hoarse cry, protruding tongue, hypotonic muscles of the abdomen with constipation, abdominal protrusion, umbilical hernia, subnormal temperature, lethargy, excessive sleeping, slow pulse rate in cold and mottled skin, stunted skeletal growth, and travel appear with dwarf and short limbs. Diabetes, a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both, classified into 4 categories. Type 1 is caused by autoimmune beta cell destruction, leading to absolute insulin dependency. Type 2 is caused by progressive loss of beta cell insulin secretion, frequently with a background of insulin resistance. Gestational diabetes is diagnosed in the 2nd or 3rd trimester of pregnancy. That was not clearly overt diabetes prior to gestation. A specific type of diabetes mellitus due to other causes. Specific types of diabetes include monogenic diabetes syndrome, such as neonatal diabetes and mature onset diabetes of the young. Diseases of the exocrine pancreas, such as cystic fibrosis, and drug or chemical induced diabetes, such as steroid use or AIDS virus, or after organ transplant. Diagnosis is based on A1C levels, fasting plasma glucose levels, oral glucose tolerance tests, or random glucose levels in an individual with symptoms. Glycosylated hemoglobin refers to the permanent attachment of glucose to hemoglobin molecules and reflects the average plasma glucose exposure over the life of red blood cell, approximately 120 days, and provides more accurate measure for monitoring long-term control of blood glucose levels. Type 1 diabetes mellitus, the most common pediatric chronic disease. It is either idiopathic or autoimmune. Idiopathic type 1 is less common and has a strong genetic component affecting individuals that have no evidence of beta cell autoimmunity and have varying degrees of insulin deficiency. This is a slowly progressive disease that destroys beta cells of the pancreas with strong environmental factors such as certain drugs, foods, and viruses. These interactions result from the formation of autoantigens that are expressed on the surface of the beta cells and circulate in the bloodstream lymphatics. Cellular immunity and humoral immunity antibodies against islet cells, insulin, glutamic acid decarboxylase oxidase is stimulated, resulting in beta cell destruction and apoptosis. Over time, 80 to 90% of the insulin secreting beta cells of the islet of Langerhans are destroyed. Insulin synthesis declines in hypoglycemia. Hyperglycemia develops. Insulin normally suppresses secretion of glucagon, and thus hyperinsulinemia leads to marked increase in glucagon secretion, is produced by alpha cells, and acts in the liver to increase blood glucose levels by stimulating glycogenesis. Clinical manifestations: polydipsia, polyuria, polyphagia, weight loss, fatigue, recurrent infection such as boils, carbuncles, and bladder infection, prolonged wound healing, genital pruritus, visual changes, paresthesia, and cardiovascular symptoms such as chest pain, extremity pain, and neurological deficits due to macrovascular disease. Evaluation and treatment. Diagnosis criteria for diabetes type 1 is hemoglobin A1C greater than 6.5%, or 2, fasting glucose greater than 126, which is defined as fasting no caloric intake for at least 8 hours, or number 3, a 2-hour plasma glucose greater than 200, or 4, an individual with classic symptoms of hyperglycemia or hyperglycemia crisis, which is a random plasma glucose greater than 200. In the absence of hyperglycemia criteria 1 through 3, diagnosis requires 2 abnormal tests from the same sample or in 2 separate test samples. There are no approved treatments for preventing destruction of the beta cells. Treatment is targeted at controlling glucose without episodes of hypoglycemia. Management includes type of disease, age, activity level, but all individuals require some combination of insulin therapy, meal planning, and exercise regimen, and glucose monitoring. There are several different types of insulin available, new technologies for more physiologic insulin delivery systems. Type 2 diabetes mellitus. This is non-insulin dependent diabetes. There's an increase in type 2 among children, especially those that are obese, attributed to genetic abnormalities combined with environmental influences, insulin resistance, decreased insulin secretion by beta cells. The most common, well-recognized risk factors are family history, age, obesity, hypertension, poor diet, physical inactivity. Increased evidence that diet, including diet during pregnancy, influences the long-term risk of type 2 diabetes in children and adults. Diets high in fruit and vegetables, fiber, and nuts reduce the risk. Diets high in simple carbs, saturated fats, and red meat are associated with an increased risk. Weight gain and lack of exercise also contribute. Insulin resistance is defined as suboptimal response of insulin sensitive tissues, especially liver, muscle, and adipose tissue to insulin. Mechanisms that contribute to insulin resistance include insulin molecules, high amounts of insulin antagonists, downregulation of insulin receptor, and alteration of glucose transport proteins. Obesity is one of the most important contributors to insulin resistance and diabetes, and acts through several important mechanisms. Adipokinins or cytokines produced by adipose tissue, which increase serum levels of leptin and decrease levels of adiponectin result in inflammation and decrease insulin sensitivity. Free fatty acid increased along with intracellular deposits of triglycerides and cholesterol lead to decreased tissue responses to insulin. Inflammation, adipocyte associated mononuclear cells and inflammatory cytokines released from adipocytes induce insulin resistance and are cytotoxic to beta cells. Mitochondrial dysfunction, decreased insulin induced mitochondrial activity, lead to insulin resistance, hyperinsulinemia. Obesity is correlated with hyperinsulinemia and decreased insulin receptor density. Pancreatic alpha cells become less responsive to glucose inhibition, resulting in an increase in glycogen secretion, increasing the blood glucose level by stimulating glycogenesis. Clinical manifestations are nonspecific. A patient may show some classic symptoms such as polyuria and polydipsia, but more often will have nonspecific symptoms such as fatigue, pruritus, recent infection, visual changes, or symptoms of neuropathy. The affected individual is often overweight, dyslipidemia, and hypertensive. The diagnosis, same as in type 1, there's also risk of developing metabolic syndrome, where 3 of the 5 following traits must be present: increased weight, circumference greater than 35 inches in women, 40 in men, plasma triglycerides greater than 150, plasma HDL less than 40, blood pressure greater than 130, systolic 85, diastolic, plasma glucose greater than 100. The goal of treatment is to restore a patient to normal glucose levels, correct any metabolic disorders. Prevention for prediabetes hinges on diet and exercise, consuming more complex carbohydrates, foods low in fat, adequate protein and fiber. Obesity management results in improved glucose tolerance. Bariatric surgery improves glycemic control and decreases the risk of cardiovascular disease. Currently, metformin is considered the primary pharmacological choice for treatment of type 2 diabetes, and if target is not maintained over 3 months, GLP-1 receptor agonists may be added. Addison's disease. The primary adrenal insufficiency that's relatively rare and occurs in adults 30 to 60 years, caused by autoimmune mechanisms that destroy adrenal cortical cells. Chronic infections that affect adrenal glands, such as TB, account for the majority of cases. It's characterized by inadequate corticosteroid and mineral corticoid synthesis and elevated levels of serum ACTH, which is a loss of negative feedback. Idiopathic Addison disease causes adrenal atrophy and hypofunction, is an organ-specific autoimmune disease resulting from autoantibodies and autoreactive T cells that attach the adrenocortical cells. If it occurs in childhood, it's type 1, or in adulthood, it's type 2, associated with other autoimmune diseases, especially Hashimoto thyroiditis, pernicious anemia, and idiopathic hypoparathyroidism. Addison's disease may be inherited as autosomal recessive trait. Clinical manifestations. Symptoms of Addison disease are the result of hypercorticolism and Hypocritoralism. Symptoms begin with weakness and easily fatigability. Skin changes, including hyperpigmentation and vitiligo, may occur. As the condition progresses, anorexia, nausea, vomiting, diarrhea may develop. The greatest concern is the development of hypotension that can progress to complete vascular collapse and shock. This is known as adrenal crisis or Addison crisis, and most often develops in individuals who have undiagnosed disease and experience psychological stress. Evaluation and treatment. Serum urine levels of cortisol are depressed with primary, and ACTH levels are increased. Due to hydration, BUN levels may increase. Serum glucose level is low. Eosinophilia and lymphocyte counts are elevated. Hyperkalemia, mild alkalosis. The ACTH stimulation test is used to evaluate serum cortisol levels. Treatment involves steroid replacement therapy with dietary modification and correction of underlying disorders. The individual's diet should include at least 150 milligrams of sodium per day and should be increased if individuals experience excessive sweating or diarrhea, or with acute stressors such as infection, surgery, or trauma. Additional cortisol should be administered. Cushing's disease refers to an excess endogenous secretion of ACTH. ACTH-dependent hypercorticolism results from the overproduction of pituitary ACTH, uterine adenoma, or ectopic secreting non-pituitary tumor, such as small cell carcinoma of the lung. ACTH-independent hypercorticolism is caused by a cortisol secretion from a rare benign or malignant tumor of one or both adrenal glands. A Cushing-like syndrome may develop as a side effect of long-term pharmacological administration of steroids. The excess ACTH stimulates excessive production of cortisol. There is a loss of feedback control of ACTH secretion. In individuals with ACTH-dependent hypercorticolism, secretion of both cortisol and adrenal androgens is increased, and cortisol-releasing hormone is inhibited. In contrast, ACTH-independent secreting tumors of the adrenal cortex generally secrete only cortisol. Elevated cortisol levels suppress CRH and ACTH levels. When the secretion of cortisol by the tumor exceeds normal cortisol levels, symptoms of hypercortisolism develop. Clinical manifestations: weight gain is the most common feature, results from accumulation of adipose tissue in the trunk, facial, and cervical areas, and are described as truncal obesity. Moon face, buffalo hump, thinning of scalp hair, emotional instability, acne, increased facial hair, osteoporosis, cardiac hypertrophy and hypertension, adrenal hyperplasia and tumors, striation of skin, easily bruised, muscle weakness, and the extremities, and diabetes mellitus are other symptoms. Routine lab results may include hyperglycemia, glycosuria, hypokalemia, metabolic acidosis, serum and urinary cortisol levels, serum ACTH levels, and dexamethasone suppression testing are used to confirm the diagnosis and to determine underlying disease. Late evening salivary Cortisol levels are used as a screening as well as tumor detection with imaging. Treatment is specific for the cause. It includes surgery, medication, and radiation. Differentiation between pituitary, active P, and adrenal causes is essential for effective treatment. Without treatment, individuals with Cushing's syndrome have a high risk for developing overwhelming infection and significant complications from generalized atherosclerosis and hypertensive disease. SIADH. Characterized by high levels of ADH in the absence of normal psychological stimuli for its release. Common cause, ectopic production of ADH by tumors, such as cancers of the lung, stomach, pancreas, bladder, prostate, and endometrium, lymphomas, and sarcomas. Pulmonary disorders associated with SIADH include pneumonia, tuberculosis, asthma, cystic fibrosis, and respiratory failure requiring mechanical ventilation. Central nervous system disorders include encephalitis, meningitis, intracranial hemorrhage, tumors, and trauma. Iatrogenetic causes include surgery and medication that increase ADH secretion for as long as 5 to 7 days after surgery. It is likely related to volume and fluid changes after surgery. The amount and type of IV fluids given and the use of narcotic analgesics. Additional medicines include narcotics, general anesthetics, antidepressants, antipsychotics, chemotherapeutic agents, and NSAIDs. Pathophysiology. The cardinal feature is the result of enhanced renal free water retention. ADHD induces the insertion of a water channel protein called aquaporin 2 into the tubular lumen membrane, which increases water reabsorption by the kidneys, results in expansion of extracellular fluid volume, leads to dilutional hyponatremia, hypoosmolarity. Urine is inappropriately concentrated. Water is reabsorbed that normally would be excreted. Symptoms result from hyponatremia, determined by its severity and rapid onset, thirst, impaired taste, anorexia, dyspnea on exertion, fatigue. Dull sensorium occurs when the serum sodium levels decrease rapidly. GI symptoms, including vomiting, abdominal cramps, occur with a drop in sodium concentration from 130 to 120. Weight gain from water retention, but peripheral edema is absent. Serum sodium levels below 115 cause confusion, lethargy, muscle twitching, convulsions, and severe and sometimes irreversible neurologic damage, with symptoms resolving with correction. Evaluation and treatment is based on serum osmolarity and hyponatremia, urine hyperosmolarity, and the absence of conditions that can alter volume status. Treatment involves correction of any underlying problems, fluid restriction, carefully monitoring sodium status and neurologic symptoms, administration of vasopressin receptor antagonists, so VAPANs. In severe cases, emergency correction by careful administration of hypertonic saline may be required. Resolution occurs within 3 days. If hyponatremia is corrected too rapidly, a severe neurosyndrome called central pontine myelinolysis can occur.